All right. Well, welcome to Chapter 3 in your Advanced EKG class. This chapter is relatively short, and we're going to be talking about determining axis deviation and identifying hemiblocks when we see those. Now, I want to preface this by saying that we're going to be learning in Chapter 4 about bundle branch blocks. And those are going to be much more critical to our paramedic 12-lead interpretations than determining axis deviation and recognizing hemiblocks. But this is a very good review. It's a very good introduction into how the heart works. So we're going to briefly touch on it. Don't spend a great deal of time racking your brain on understanding this because if you do any investigation at all, you can see that this axis deviation gets really, really involved and requires a lot of calculations and ways of identifying more than we're going to do at the paramedic level. So we're going to just be familiar with the basics of it, and then we're going to jump into Chapter 4 and take what we know from this and apply it to our bundle branch blocks, and will make us very astute at what we need to do with our 12 leads. So our objectives in this short talk are going to be to talk about and understand the intraventricular conduction system, that conduction within the ventricles. We're going to define what axis is, and based on what the normal axis is, we should be able to recognize any axis deviation or something that is deviated from that normal. We're going to be looking at a real simple chart that's going to help us determine axis deviation and the presence of a hemiblock. And then we're going to talk about the clinical significance of why that's a big deal for us and why we should be able to recognize that. Now, in the past, the traditional method of identifying axis deviation was called the hexiaxial system. And it was putting 6 different limb leads on at various angles, and then you measured those in, and you looked at each lead, and you determined the quadrants, and it was very tedious. If you don't like math, this is an absolutely horrible process. Very difficult to master. Now, luckily for us, we've got 12-lead machines that quite frequently measure this for us a lot, but we're going to be able to recognize it easily with this simple system. Okay, so axis in a nutshell is the direction that the electricity travels from the SA node down through the heart. Now, if you look, we're looking at limb leads here. So we've got limb 1, which is going to be on the patient's left arm. You've got limb 2 on their left leg, and you've got limb 3 on the right leg. So those are the 3 leads that we're looking at. Okay, and we're going to see how the electricity moves through and how this appears in those leads. Okay, now just really quickly, a brief overview on how the electrical system travels in the heart. This is uber simplified, and I love it. Okay, you can see that the heart sits inside the chest at an angle. It does not sit with the atriums directly over the ventricles. It's angled a little bit to the left. So when our SA node produces electricity, that electrical impulse comes down through the atrium and is collected in the AV node. Again, the job of that AV node is to collect that electricity and then hold it for just a fraction of a second while we allow the ventricles to fill and the valves at the top of the ventricles to close. Otherwise, when the ventricles contracted, it would be boom, boom, and the blood would shoot right back up in the atrium, and we would get nowhere pretty quickly. So that AV node holds that electrical impulse, and then it shoots it down this bundle of His, which basically is the base of the AV node, so to speak. It's very short. And that bundle of His brings that electricity down into the septum of the ventricles, and from there it branches off. And so it's going to branch off into the right bundle branch and the left bundle branch. Okay. Now this left bundle branch is very short and stubby right here, because you can see it very quickly bifurcates or splits into two branches, the posterior fascicle and the anterior fascicle. Now, this is what we're talking about when we're talking about axis deviation. We're dealing with fascicle blocks or blocks within these fascicles. And so we're going to measure where these are blocked and which ones are blocked based on how the electricity comes down and shoots down through here. So this is kind of easy to recognize once you just understand a few quick rules. Okay, so the left bundle branch obviously activates the left ventricle, and the right bundle branch activates the right ventricle. So when we're talking about axis deviation, because we're dealing in these fascicles, we're primarily looking at the left ventricle. Okay, so this left bundle branch right here, from the bundle of His down to where it splits off into the fascicles, is very short. Okay, it splits off, and the left posterior fascicle. So now, just based on this name, we know posterior. It's going to hit the. It's going to be more towards. It goes back into the backside of that left ventricle. So the left posterior fascicle is relatively short and broad, and it's got a dual blood supply to it. Okay, there's two coronary arteries that feed into that. So because of that, it's pretty resistant to ischemic damage. If one of those coronary arteries gets blocked, the other one fills in for it. So we don't have a lot of danger of ischemic damage to that posterior fascicle. Okay, it transmits impulses to the papillary muscles, which leads to that mitral valve closure. So when our electrical impulses first come down into the ventricle, very quickly before the contraction happens, just very briefly, those papillary muscles are stimulated by this posterior fascicle, and it causes that mitral valve to close and eliminates, or is kind of a safety measure against blood regurgitating back through there. Okay, the left posterior is broader and shorter than the right, and so it reaches those muscles quicker. Okay, basically what happens, it's kind of like it's a pre-tensioning of the chordae tendineae, which are the cords that hold those valves shut, or shut the valves. And so it's kind of like a pre-tensioning on your seatbelt that when you get in and you buckle your seatbelt, it measures how much it's going to take to hold you in there. And that way, if you're getting ready for a big impact or a big jolt, it's ready for it. Same thing happens with this fascicles. They get the chordae tendineae pre-tensioned, and then they're ready when that big contraction hits in the left ventricle to hold that blood back, so it is forced out the aorta rather than back up into the left atrium. Make sense? Okay, so you can see here how the heart kind of sits inside the chest here, and you can see where your leads would be based on this heart. Now, we're not looking at these precordial leads or the chest leads. We're looking at leads 1, 2 down on the left leg, and then 3. Now, based on how this heart sits in the chest where our leads are, you can see when the impulses leave the SA node up here, they come down through the atrium, they hit the AV node, and then they come down to this apex of the heart in the ventricles. So because this is coming downward, it's moving towards those leads. So it's moving towards a positive lead. And the positive leads are going to show up when electricity moves towards it with a positive deflection. So in lead 1, it's coming from the right side towards lead 1, slightly, definitely towards lead 2, and definitely towards lead 3. So we're going to see a positive deflection or an upward deflections in each one of those leads when our electricity moves in this normal pattern through the heart. Okay, now let's see what happens when it doesn't. Okay, now this is called a physiological left axis deviation. So you can see it comes down from the SA node through the atriums, hits that bundle of His, and comes part way down. So it's coming part way down through the ventricles and then moving off towards that left ventricle. Okay, this is a fairly common thing. It usually has very little hemodynamic effects, but it's pretty common in both obese people and athletes, highly trained athletes. And I'm not quite sure how that plays in because you've got like both ends of the spectrum there. I understand with athletes because we have a much bigger muscle mass in our left ventricle because the heart has to work so much harder to meet the oxygen demands that's put on it. And I can see where sometimes this heart muscle under stress with the athletes can become a little bit hypoxic there and causing that deviation. And the same thing maybe with our obese people, not so much the oxygen demand, but the unhealthy state of the heart may cause a little bit of ischemia in those heart tissues, which causes this deflection. So how we see this physiological left axis, which means when the electricity starts to come down through those fascicles, they're somewhat blocked, and so that electrical impulse is pulled off into that heart muscle. So what we see is, if you look at how the direction is coming, it's coming down somewhat towards lead 2, but then it changes and goes upward. So instead of coming down like it should towards lead 3, it doesn't. So we see a negative deflection in lead 3. We see a positive in lead 1. And then lead 2 over here, depending on where this turns, it could be positive or it could be half and half. Okay, so we're going to look at how to measure this. Okay, in lead 2, if we want to count from the isoelectric line to down, we can count how many blocks. Okay, and we can easily see this is a negative deflection. You can easily see up here in lead 1, this is a positive deflection. Nothing goes below the isoelectric line. But if you look in lead 2 and this half and half, it's a little above and a little below. So do we call that positive or do we call it negative? And to do that, what we're going to do is we're going to count the number of boxes from the isoelectric line to the peak of the positive deflection. And then we're going to count the boxes from that same isoelectric line to the peak of the negative deflection. And then we'll subtract the negative ones from the positive ones. If you have more positive, you're going to have a positive number. We're going to call that a positive deflection. If you have more negative boxes, then let's say we're going up 4 boxes and down 5. So when we subtract 5 from 4, we're going to have a negative 1. So that's a negative deflection. Okay, make sense? So again, this is a physiological left axis, which isn't all that horribly uncommon, and hemodynamically is not really terrible. But this one is your pathological left axis, and this is caused by a hemiblock, meaning that fascicle is completely blocked. And we're going to recognize that because the electrical conduction path is going to change. If that's blocked, we can't get electrical conduction through there, and we're going to recognize that. Okay, so when it comes down from the SA node, down through the AV node, passes through that bundle of his, hits that fascicular block, and shoots it into the Purkinje fibers and things right at that point. So we don't get that downward deflection at all through the ventricles. And what we're going to see here in this pathological left axis, lead 3 is going to be completely negative because our electrical conduction is not even thinking about going that way. Okay, it's through the ventricles, not even coming down to lead 2, but it's going strictly to lead 1. So we're going to see a negative in 3, negative in 2, positive in 1. So that tells us the only direction that this electricity is passing is up into that left arm lead. Okay, so it's going up. These patients are 4 times more likely to arrest if they're having a hemiblock and chest pain. So if you've got somebody that has chest pain, you throw a 12 lead on them, and you see this, there's a disease process that's going on in the heart that's keeping that electrical conduction from going through. So we already have a diseased heart. We have an issue with electrical conduction. We probably have an issue with circulation, which is the precursor to the disease or the cause of the disease. So we have a sick heart here, and if we see that, you want to perhaps prepare for the worst. Okay. Now, right axis deviation is where it's going to come down. This is actually fairly rare, but it's going to come down that bundle of his, start down through that right fascicle, get blocked, and it's going to shoot down towards the right ventricle. Okay. This is almost always pathological or associated with diseased or sick cells. It is rare, and it's associated with the posterior hemiblock. So the backside of that heart fascicle is going to be blocked. So what we're going to see is we're going to see lead 3 is positive, but 2 and 1 and 2 will be negative because our deflection is coming down and it's going right straight down to that right leg limb lead. That's a lot to say. Okay. So extreme right, and this one is kind of cool. If you can see here, we don't have any conduction at the top part of the ventricles. So we may have some conduction in the atriums, maybe, but it's not getting through the AV node if we do have some. And so the ventricles are in essence starting this. So instead of the electrical impulse coming down through the heart, it's going to start in the base of the heart and go up. And so looking at lead 3, it's wide and negative. 2 is the same. 3 is also wide and negative. All 3 of them look like V's, and that is because this is a ventricular rhythm. Most commonly, you're going to see this as V-tach. Okay, so we see that there's just this block here. It's not getting through, so the ventricles are having to produce their own electricity. So the fascicular block, or a hemiblock, is a block of one of the 2 fascicles that come down. Remember, those fascicles come off the left bundle branch block. Okay, so they're not as big a deal as a bundle branch block because they're lower than that. But they are a big deal because they interrupt the conduction in the left atrium. Okay, so we're going to diagnose this with a 12-lead ECG. Okay, and it's based on that axis deviation. Okay, so we'll talk about that. Pathological left axis deviation, or that anterior hemiblock. Okay, we're going to see that it's going to come down to anterior is the front side of the heart. So that anterior fascicle is going to branch off, and if it's blocked, again, we have a 4 times higher mortality rate. With the posterior, we have a 4 times chance of them arresting, but 4 times higher mortality rate when it's in the front part of the heart, if they're having an MI. So because this anterior fascicle is up so high, it blocks the impulses very high in the ventricles and therefore causing major damage. I mean, we're not going to have any conduction through the ventricles, and you can tell just based on our anatomy, if we don't have conduction through the ventricles, we are not going to have cardiac output. And therefore, first of all, our heart cells or our cardiac cells are going to become ischemic, and we're going to have that MI, but ultimately we're going to have a system failure because we're not going to be able to oxygenate. If we can't oxygenate our heart, we're not going to be able to oxygenate our kidneys or our brain or any of those other things. So this is very significant in an emergency when you see it. Okay, the posterior hemiblock is going to show up as right axis deviation, a very high mortality rate. It's a serious problem because it involves two coronary arteries. So we're not talking an occlusion, we're usually talking two when we see this. And so you're going to see this as it deviates to the right. We're going to see that lead 3 is positive, the other 2 are negative. Okay, so determine the axis. We're going to, and it says here run leads 1, 2, and 3. But if you're doing a 12 lead, you're already running those. So you just have to take a look at those 3 limbs and look to see what you see. Okay, these leads have got to be on the limbs to do this. You can't put them on the shoulders and the abdomen. They've got to be out on the limbs. So we're going to look at the QRS deflection in each one of those leads. Okay, do they go up or do they go down? Or are they halfway? Are we measuring? And then we're going to look at this chart that I've got for you. I have put this chart on your course page so that you can see it from there. But I think you're going to find it very handy to use for this. None of this is hard, and it's really easy because when you do a 12 lead, it automatically calculates your angle or your degree of deviation. In the past, we had to calculate this manually, and it was so painful that I never learned how to do it. So, but when you've got a 12 lead, it's going to automatically calculate it. So you just look in your readout at the top of your sheet. A lot of times what we read is the pulse, the beats per minute, and we don't go any further. But we can because we're going to know what QRS axis is or R axis is. So if you look, you're going to see a number. It's in the middle if it's reading R axis, or QR axis will just be a printout. It's going to give you a number. And then we're going to take this number and we're going to apply it to the chart that we have here. Okay, so understanding a normal axis is 0 to 90 degrees. And when we have no deviation from that, we're going to see an upward deflection in all 3 of our leads. And we just talked about all of this. We're just adding this number into it now. Okay, so when we have a physiological left axis, which remember isn't all that big of a deal, we're going to see a 0 to a negative 40. Okay, so this is 0 to 90. When we have a left deviation, it goes to the negative numbers. So 0 to negative 40 degrees, we're going to see upward in lead 1, upward or halfway in lead 2, and a negative deflection in lead 3 because it's swinging a little to the left. Okay. If we have a pathological left axis deviation, which is worse, we're going to see that negative 40 degrees to negative 90 degrees. Now, notice these are all negative numbers. So we're going to see an upward in lead 1 because that's the very far left, and then a negative deflection in 2 and 3. That is your anterior hemiblock. Remember the front side of the part, 4 times higher mortality rate if they're having an MI with that. Then looking at the positive numbers, because this is right deviation, 90 to 180, we're going to see a downward deflection in 1. Because remember, that's your left side. So we're going to see negative there because it's headed to the right. So we'll see a positive or a negative. It could be anything in lead 2. And then a positive deflection in lead 3. That is your posterior hemiblock. Okay, it's blocked in the back, so it's coming around to the right side. And then your extreme right axis deviation is anything more than 180 degrees. And we're going to see that negative deflection in all 3 leads because this is a ventricular rhythm, okay, most often VTAC. Okay. So there's a bunch of 12 leads here to practice. So again, we're looking in leads 1, 2, and 3, which are right here. And see, we've got a positive, negative, positive, half and half, negative. So what is a positive, half and half, negative? Go to your chart. Okay, we've got a positive, half and half, negative. So we have a physiologically left axis deviation with this. Okay, so there's lots of 12 leads here for you. I have posted all these just with the 12 lead in a document on your course page. Now, look at those because they don't have the diagnosis right at the top. Look at those, see if you can figure out what they are, and then come back to the PowerPoint, which I've also put on your page, and see how close you were. Be good practice for you. It won't take you too long. You don't have to do a lot, but it's good to understand how to recognize those hemiblocks. Those hemiblocks are diagnosed only through axis deviation. Okay. When we get to bundle branch blocks, which is in chapter 4, those do not use axis deviation. Okay, so the difference is the hemiblocks or a block are blocks in the fascicles of the left ventricle. Okay, those little branches off of that left bundle branch. When we get to chapter 4, we're going to look at actual blocks within the bundle branches themselves, which are different and a little more significant in our patient outcome and something we should recognize. So this is kind of the lesser of the two evils, and we're going to jump into chapter 4 with bundle branch blocks. So have fun with this. I will see you soon.